these individuals and why we should care about them. The next thing I'm going to talk about is what is normal cognitive aging. A lot of people come to me saying, Doc, I think I'm having memory problems. Is this normal? Is there something else going on? So I'm really going to talk about specifically the different types of thinking skills or abilities and what changes as we age and what doesn't change in normal aging. I'm also going to talk about something called mild cognitive impairment, as well as something called major neurocognitive disorder, which was originally termed dementia, but the new label for it is a major neurocognitive disorder. And these are both not normal aging. Then we're going to kind of talk into the brain structures about what changes in the human brain as we age, from both a cellular as well as a network approach. And then finally, we're going to really get into how does social isolation, loneliness, and cognition relate to each other, and why it's so important that we have interventions for reducing social isolation and loneliness in older adults, because spoiler alert, loneliness and social isolation as themselves are independent risk factors for developing future cognitive decline in older adults. And so it's so important that we talk about, okay, if we know that loneliness is a risk factor for cognitive decline, what are some strategies or interventions that we can do to reduce this in our community? Next slide, please. So first off, who is old? When I'm saying the older adult population, there really are different constructs when we're talking about old, or how we have defined aging. There's a biological age, but there's also this psychological age. It doesn't really happen in days. So aging happens over years or decades, and there's really no one age when anyone is considered old. But for today, I'm going to be considering anyone age 65 and older as in the older or aging population. And one of the reasons why we have individuals that are living to longer ages is because our life expectancy has increased over the last century. So in 1910, the life expectancy for men and women respectively was 48 and 52 years of age. So if age is the biggest risk factor for developing something like dementia, people didn't live that long to have these conditions, but now in 2010, the life expectancy has jumped to 76 and 81 years respectively for men and women. So more and more individuals are aging, and they're having and developing conditions and chronic medical illnesses that are more likely to impact you as you age. So we really need to know about these conditions. Next slide, please. So here's that silver tsunami that I was talking about. And why is this so important? Well, there is this exponential growth that is happening in our older adult population. Basically, the baby boomers, so after World War II, all those baby boomers were being born from 1946 to 1964, and they're getting older right now. And they are representing a larger proportion of our population. And so as they age, we need to really recognize, okay, how are we going to take care of this member and these members of our community, and make sure they have good quality of life? And if there's something that we can do to improve their quality of life, how can we help? So it's anticipated that by 2050, the population of individuals age 65 and older will be projected to 83.7 million people. And that's almost doubling from what it was in 2012. So this is going to be a significant number of individuals who are living older and who are in these aging populations. Again, this is really due to the baby boomers as they age, and it's so important for us to know about. Next slide, please. So I'm a very visual person, and this is just two charts that basically show the percentage of individuals of the population who are age 65 and older, broken down by decade. And as you can see, we have this steep increase and this exponential increase in the proportion of our population who's 65 and older. Next slide, please. So before I kind of get at, what is normal cognitive aging, the first thing that I need to talk about is that there are some limitations for studying aging and cognition. And I'm going to talk about each of those in a little bit. So the first one relates to something called the recruitment bias. Basically, this means that only the healthiest and sometimes most advantaged individuals are likely to be included in these studies. And so it might underestimate the degree of cognitive decline in normal aging. The next one is the misclassification bias. So this is sometimes individuals are tracked and followed long-term in something called longitudinal studies, where they are tracked over periods of years in the same study, and you try to figure out the trajectory of each individual in that study. But it might be that they were misdiagnosed or misclassified earlier on, and so that they're not actually a healthy control, but they were someone that will develop mild cognitive impairment or even dementia. And this might overestimate the degree of cognitive decline attributed to normal cognitive aging if they're misclassified as being in the healthy controls. Next one being just related to the study biases themselves, so the design of the research studies that are done. And randomized controlled trials, or RCDs, are the best and kind of gold standard for studying individuals and for doing research. But there could be things called cohort biases. So this occurs when you are trying to compare two groups of individuals and you try to match them by age and say, okay, they're matched by age, so everything else must be equal in proportion to other factors. But it doesn't really take in that there can be other variables that are different between the two cohorts and the two groups that are accounting for these changes on the cognitive measures, and it's not just normal aging. The final one is practice effects, okay? So this is really important, especially if you have something called a longitudinal study, where you are having individuals or research participants completing the same tasks multiple times. They might get really good at that one task, and this might underestimate the degree of cognitive decline in normal aging. So what we do is we try to have similar batteries that are measuring the same cognitive constructs, but we use alternate forms, and this can be helpful in reducing those practice effects. And then the last thing is attrition bias. In longitudinal designs, unfortunately, individuals will fall out or will no longer be participating in the study. And so how do we manage and predict who is more likely to remain in the study and who is not more likely to remain in the study, and what factors might influence that attrition rate? So all of these need to be taken into consideration when we're talking about the normal cognitive aging literature. Next slide, please. Next slide, please. So what are these normal cognitive changes? So we're going to go back all the way to the 60s, where we have this really pivotal theory that came out by Cattell and Horn, which is their intelligence theory. They're trying to say, okay, how do we actually measure what intelligence is? And this is, again, they're trying to figure out, okay, if everyone has intelligence, who's more intelligent, who's less intelligent, and how do we actually measure that or observe this phenomenon? And what they did was they used a factor analysis, which means that they broke up intelligence into two main factors or latent variables. The first being something called crystallized intelligence. So overall intelligence is composed of two factors or two variables, crystallized intelligence and fluid intelligence. Crystallized intelligence are the skills and abilities and knowledge that are overlearned. This is really influenced by our cultural experiences, our education, and just our experiences with the environment. And overall, what we know about crystallized intelligence is that this remains quite stable until the 6th or 7th decade of life, and then it kind of naturally does decline, but not to the degree of something called fluid intelligence. So an example of something that's crystallized intelligence would be like your vocabulary or your reading skills or your trivia, what we call our general fund of knowledge. These are learned, these are extracted from our experiences with our culture and with our environment, and these are not innate. As opposed to, next slide please, fluid intelligence. So fluid intelligence on the opposite side are these innate qualities that are involved in our thinking skills. These are not learned. These are based on our genetics, they're based on our biology, and these are really our ability to problem solve, to reason, critical thinking skills, our language skills. All of these are called fluid intelligence abilities. And what we unfortunately know is that these peak in the third decade of life and then gradually decline with normal natural aging. So I'm 32 right now, and so I've kind of hit my peak, and everything's kind of downhill from here, but that's okay because it's normal cognitive aging. So an example of this is things like processing speed or our attention skills. Our memory is also a fluid intelligence ability. And so we would expect normal natural changes to our memory skills as well. Next slide, please. Again, I'm a very visual person. So if you look at the bottom right-hand graph, you see crystallized intelligence as, again, if it's based on our experiences, based on our cultural, based on things that we learn, we're always learning throughout our whole life, and we would expect that to increase as we age and then kind of peak in the middle age or the older adult age. Versus that blue line of fluid intelligence, we see that it kind of peaks within the young adulthood and then naturally gradually declines. Okay? All right, next slide, please. I'm going to go over some of these fluid intelligence or some of these different types of cognitive skills or thinking abilities and what they actually mean. So I like to use a lot of metaphors when I talk about thinking skills. And the biggest one that I like to use is a house, okay? So if we have a house and we're trying to build up our thinking skills like a house, processing speed and attention is kind of like the foundation of your house. Everything else depends on the speed at which your brain is able to take information in, process that information, and kind of spit it out. This is the most basic abilities of our brain to be able to perceive stimuli in the environment, process that information, and then respond accordingly. But what we know as we age is that our sensory perception and our processing speed naturally decline. Thus, because of a slow processing speed, when we add complexity to tasks or make it more challenging, we build up off of that foundation, it's going to be a little bit more challenging for the normal natural aging process. And again, sensory perception is so important here. So as we age, our hearing and our vision naturally declines, which is going to impact our ability to perceive initially the information from our environment and then process that information accordingly. And again, this natural decline in processing speed is part of the normal aging process. Next slide, please. Which leads me to my next layer in our house, our attention networks. This is kind of, again, the foundation, but it's also the framing of the house, so to speak. There's no one area of the brain that's in charge of attention, but we have these amazing networks, basically, that are sending information to and from different areas of the brain for it to be processed. So it's kind of like highways in your brain, and attention and processing speed are traveling along these highways. Attention is basically your ability to focus and concentrate on specific stimuli. And there's different types of attention. At its most basic is something called simple attention. And this is basically being able to take information in really, really quickly and spit it out. So things like if I read you a list of 5 numbers, being able to repeat those numbers very, very quickly. This should remain normal and not change as we age, okay? This does decline slightly later in the 80 and the 90-year-olds, but not in normal cognitive aging in the 50, 60, 70 decade. And then there's a couple more complex attention skills. There's something called selective divided attention, as well as something called working memory. Selective attention is basically our ability to focus on specific information from the environment while ignoring irrelevant information that also is trying to pull you away or pull your attention away. So this is things like if you're at a supper party and there's lots of different conversations going around at the table, being able to selectively attend to the conversation next to you while ignoring all the other little chatter that's going around you. Similar to that is something called divided attention. This is really our brain's ability to focus on multiple tasks simultaneously and switch back and forth efficiently to be able to do them correctly and without errors or mistakes. So this is kind of like if you were talking on the phone with a loved one and preparing a meal at the same time. This is the divided attention task. This usually peaks unfortunately in the 3rd and 4th decade and then gradually declines after that with normal aging. A third type of attention skill is called working memory. And for this type of skill, I like to think of it as your brain's chalkboard or your brain's whiteboard. So it's your brain's ability to take information, manipulate that information in some way, and then spit that information out, okay? So think of it like if you have to do an arithmetic problem in your head. You have to multiply something, you have to divide something. You are taking the information in, manipulating it, holding multiple information components at the same time, and then processing it as quickly as possible. That's working memory. Next slide, please. All right, so the next type of fluid intelligence is something called language, okay? So that's what I'm using right now, my language skills. And there's 2 different types of language. There's our ability to express language, and then there's also our ability to comprehend or understand language. And there's a little bit of mixed results in the literature about whether or not these actually maintain or do they naturally decline with normal aging. So the 2 things that I'm going to talk about is naming. So our ability to come up with names of common objects, names of people, this usually remains quite stable until about age 70 and then naturally declines. The next type of skill in our language that naturally declines is something called a verbal fluency, okay? And when I see my patients, this is probably, besides memory, the most common complaint that they have. Doctor, I'm having this tip of the tongue phenomenon. I want to say a word, but I can't remember what it is. And then it's difficulty retrieving or kind of doing a mental word search through your semantic networks to try to get that information out. This, unfortunately, does naturally decline with age, okay? So it might take a little bit longer to come up with the right words, and that's normal, okay? Vocabulary, on the other hand, that general fund of knowledge, that is a crystallized intelligence skill, and that remains intact as we age. Next slide, please. Visual, spatial, and construction skills. These are housed in something called the parietal lobes, which are directly behind the ear. And the parietal lobes are basically in charge of our brain's ability to integrate and understand spatial relationships. Basically being able to take in the visual information that our brain is sending us, understanding angles, understanding how to put things together, understanding, depth perception. All of this is our spatial skills. And this usually remains intact with aging. And one of the important things of spatial skills is that you need your spatial skills in order to do one of the most complex tasks that we do safely, which is driving, okay? So if I'm noticing changes in your spatial skills, as well as your processing speed, that might be a little bit of a red flag for me to say, maybe we should get you into a driving evaluation as well, just to make sure that you're safe with driving. Next slide, please. All right, the big one, memory, okay? Everyone talks about having short-term memory changes, and there are natural changes to our memory system as we age. And I like to think about memory like a piggy bank. Again, here's my metaphors. So there's 3 different components to a piggy bank, and there's 3 different components to our brain's ability to learn, store, and retrieve information. And the top of that piggy bank, you have that slot where you want to try to encode or deposit any information that you want to hold on to, okay? And as we normally and naturally age, that slot on your piggy bank, the amount of information that you're able to learn or encode naturally declines, okay? So it's kind of like in the past, maybe you wanted to deposit quarters and half dollars into your piggy bank, but now your brain can only deposit quarters, dimes, and nickels. And that's okay. This is part of normal cognitive aging. We then have the body of the piggy bank, which is really the storage component. Anything that you want to hold onto long-term or retain is the body of the piggy bank. This body of the piggy bank, the storage or retention ability, should not change as you normally age, okay? So that piggy bank, that size of it, should remain normal and unchanged with natural normal aging. One of the classic profiles of Alzheimer's is that the body of your piggy bank, your brain's ability to store or retain information, it's actually not storing information, okay? So it's kind of like your brain's piggy bank has some cracks in it. So it's actually falling out and not being retained over time. The third component of learning and memory relates to the bottom of your piggy bank where you have that plug. You pull that plug when you want to retrieve or withdraw information that you previously encoded and stored. And this retrieval or ability to efficiently retrieve or withdraw information from our memory bank naturally does decline with aging. And that's where things like compensatory strategies are so important. So things like to-do lists, breaking tasks down into smaller steps, using Post-it notes, using calendars, all of these external cues or reminders are going to help you with being able to retrieve or unplug the bottom of your piggy bank to be able to access anything that you have learned, okay? And then there's different types of memory as well. There's something called declarative and non-declarative memory, as well as something called explicit and implicit memory. So declarative memory is something that's in our consciousness, and it's basically our ability to recall facts and events. And there's 2 types of declarative memory. There's something called semantic memory, which is our fund of knowledge. Basically, it's our memory for facts or our memory for the meaning of words. And then there's something called episodic memory, which is basically like our autobiographical memory, our ability to remember events, recent conversations, things like that. There are natural declines in both episodic and semantic memory as we age, but there's greater declines in episodic than semantic memory. And then we have something called non-declarative or implicit memory. So this is also broken down into 2 different types. Something called procedural memory, so things like being able to ride a bike. It involves motor and cognitive skills. And these implicit or procedural memory networks are remaining intact as we age, and actually they remain intact, relatively speaking, in someone with Alzheimer's disease. So they might have a decline in their episodic memory, but their procedural memory and their implicit memory, over learned information, is still intact. So we try to tap into those networks in order to try to compensate for the episodic or the semantic memory loss. Next slide, please. All right, so here's just a nice little graph again to kind of just explain, what the typical aging changes might be versus what might be the signs or symptoms of dementia. Again, occasional forgetfulness, occasional memory difficulties, that's normal cognitive aging. Occasional kind of retrieval difficulties of words, that tip of the tongue phenomenon, that's normal aging. But if we're making a lot of substitutions in our words, if we're having really frequent pauses in our speech, or if we're forgetting, our names of familiar people, names of familiar places, if we're repeating ourselves in conversation, if we're forgetting the date or important events, that is not normal aging, and then you should see one of your primary care providers, or you should go talk to a neuropsychologist to determine if this is just normal aging or not. All right, next slide, please. So we talked about the cognitive changes. We talked about, what are the skills or abilities that change, but there's always neuroanatomical changes because there's brain behavior relationships. Okay, so the brain controls all of our behaviors, our thoughts, our feelings, our emotions, and our cognitive abilities. Next slide, please. When we think of the brain, we want to try to think of it as two different components. We have something called the gray matter and something called the white matter, okay? The gray matter is the outside of the brain, as well as these very deep subcortical nuclei that are housed, and basically they're called gray matter because when we think of a neuron at the bottom of the slide, the gray matter is composed of the cell bodies or the neuron bodies, the soma, as well as those dendrite spines, okay? And this naturally declines after about age 20. And the most prominent atrophy for gray matter is in the prefrontal cortex, so right up here where our frontal lobes are. There can also be changes that are natural to the gray matter structures in our temporal lobes, as well as some of our frontal lobes. However, it's not because the cells are dying. It's because the connections between the neurons are actually getting smaller, and those spines that are around the cells of the neuron, called the dendrites, they are the area of the neuron that receives information. They kind of are like a tree where they arborize, okay, and they make new connections between different neurons. And as we normally age, the connections between the neurons also decline. So it's not that you're actually having atrophy or cell death. It's that the cells are getting a little bit smaller, and the arboration or the dendrites, connections between other cells, are getting a little bit smaller. Okay, and these are all normal, natural changes to the brain. Next slide, please. So what might be the causes? And I kind of jumped the gun here, so to speak, okay? And again, it's a decline in the size and the number of connections between the neurons as opposed to actual cell death, which is what we would see in something like dementia or Alzheimer's disease, where the cell is actually dying. And because of the loss of that cell death, the brain actually has atrophy, where it kind of shrivels up, and then that space is then there to be seen on things like neuroimaging studies, and it's filled up with cerebrospinal fluid where those cells used to be. And what's really interesting is that if we had an individual who was cognitively intact, who lived to be 130 years old, now no one's actually lived this long yet, but if someone were able to be cognitively intact and live to be 130, they would have the same changes to their gray matter structures with these the changes to the arboration of the dendrites as a person with Alzheimer's disease. So I thought that was pretty interesting. But again, it's not the cell death that's happening. It's a decrease in the complexity of the connections between neurons. It's a decline in the length of those spines of the dendrites which receive information from other neurons. And this contributes to just natural normal aging changes. Next slide, please. So that's the gray matter. The next thing that's part of the brain relates to white matter, okay? So if the gray matter is on the outside of the brain, the white matter are kind of like those highways or those connections between different gray matter sections, okay? And when we looked at that picture of a neuron in the slide before, you have something called an axon, which has a myelin sheath, okay? This is basically a layer of lipids and fattiness that helps propel or send signals quickly down the neuron, okay? And the majority of the brain actually is these beautiful white matter tracks. And they, again, are like your brain's highways or your brain's pathways from sending information from point A to point B. these naturally decline as we age. And because these naturally decline, they impact processing speed and attention. So this is really where we get those processing speed and attention difficulties in normal cognitive aging. There's a decrease in the number of axons, and the myelin in some of these axons can actually change in normal cognitive aging. Next slide, please. All right, so those are the neuroanatomical changes of normal cognitive aging. But there's something called, okay, how am I going to be successfully aging? What is the hypotheses, or what does the literature suggest that I can maintain my cognitive functioning as I age and be less likely to develop something like dementia or mild cognitive impairment? And there's something called the lifestyle cognition hypothesis, okay? And basically this just means that for some individuals who have higher or more intact thinking skills, they tend to participate in 3 types of behaviors or lifestyle choices. They tend to engage in cognitively stimulating activities. They tend to be more physically active, and they tend to be more socially active, okay? And sometimes people say, well, isn't this like a chicken or an egg phenomenon where, if you are more physically active, you're more likely to then have, opportunities to be able to use your cognition. And somebody that might have physical limitations might be less likely to engage in physical activity, which means that those networks kind of aren't being processed as well in the brain. Those connections aren't being reinforced. And so how we determine this chicken and the egg phenomenon is that we look at something called longitudinal studies, where we really track individuals over time, and we can more definitively determine, is this a protective lifestyle hypothesis, or is there something else that might be going on? And the third one is what I'm going to be talking about today, is that social engagement. And this is unfortunately one of the hardest lifestyle components of the hypothesis to test, because they're very, very subjective. So it's more easily to have an objective construct of, how many minutes you exercise a day, or whether or not you are doing things like puzzles, or, are you smoking or not smoking? These are all more straightforward objective measures that we know can influence our brain. But when we get into social engagement, there's a lot more subjectivity to it, and it's more complex, which means that we really need to be aware of what these constructs are in order to actually measure them. Next slide, please. All right, so what is not normal cognitive aging? So we talked about what is normal aging. Next slide, please. So we're going to talk about what is not normal cognitive aging. All right, so we have this nice little graph to depict what is on time on the bottom, which is in years, and cognitive decline on the y-axis, okay? And in the top in those green, this is what we would expect with normal cognitive aging, okay? We expect a little bit of cognitive decline, but nothing major, okay? However, for some individuals that go on to develop something like dementia, there are different stages of this dementing process, which are usually broken down in the research literature into 3 different domains, okay? We have the preclinical stage, which sometimes is referred to as the silent phase, because there's changes that are happening morphologically in the brain or in these biomarkers, but the individual is not showing any clinical signs on testing or on objective measures. So these are the people that come into my office and say, Doc, something's wrong. But even with my sensitive measures, they're coming up with normal aging changes. But they are knowing that something's wrong. And some of these individuals will go on to develop something called mild cognitive impairment. Mild cognitive impairment just means that there's an objective decline in your thinking skills, which is beyond what is expected for normal cognitive aging. However, you are still independent in your basic activities of daily living and your more complex or instrumental activities of daily living. So you might have objective memory difficulties from your prior baseline, but you're still able to manage the finances. You can still manage your medications. You're not having driving problems or getting lost in familiar places. This is called mild cognitive impairment, or MCI. And there is a rate of transition from mild cognitive impairment to something like dementia. And it happens in about 10% of individuals with MCI will convert to a full-blown dementia process or meeting criteria for dementia each year. Dementia means that there is an objective decline in your thinking and memory skills from a prior cognitive baseline. And because of those cognitive changes, you struggle or have difficulties with your activities of daily living. So even if you're trying your best to compensate for these changes, you might struggle with being able to balance your checkbook without help, or you might have driving changes, might be making mistakes with your medication and need somebody else to help with organizing your pill box or administering your medications. Next slide, please. So dementia really is a syndrome, okay? And basically, again, it is that there's an objective decline in your thinking skills from a prior baseline. And because of this, you're not able to complete independently, as you previously did, your activities of daily living. But there's a lot of types of etiologies or causes of dementia. Alzheimer's is the most common cause of dementia. So a lot of times my patients say, what's the difference between Alzheimer's and dementia? Dementia is the syndrome. Alzheimer's is the most common cause or etiology of dementia. We also have other types of dementias. There's over 50 types of etiologies or conditions which can cause dementia. Alzheimer's being the most common, followed by something called vascular dementia, Lewy body dementia, frontotemporal dementia, and then we have other dementias, other causes, things like a significant traumatic brain injury, HIV, excessive alcohol use or substance use or dependency. All of these can cause dementia symptoms or syndromes. Next slide, please. All right, so we're going to touch base now on social isolation, loneliness, and cognition, okay? But before we get to that, I really want to define these constructs so that everyone's on the same page with what I'm talking about. Next slide, please. All right, so social isolation and loneliness are two different constructs. Social isolation really is the objective and quantifiable reflection of your social network size or your ability to have social relationships. And this in the literature can be defined in different ways. Sometimes social isolation is defined as having a smaller social network, being unmarried, or participating in fewer activities with other people. And this is really on a continuum, okay? So we have everything from complete social isolation, where they're having no objective interactions with others, all the way to the other extremes where we have these social butterflies that are engaging in their social support networks or systems on a regular basis. And being socially isolated, it's a very big problem for older adults. And here's why, okay? Social isolation in itself is a problem because it might be due to a decrease in economic resources, or it might be because of mobility challenges, or their spouse might die, or their partner might die, and that was the person that was helping them engage in those social support systems. So if you have a death of a spouse, they might lose those social relationships and that social support network, okay? And it's so important that we recognize that social isolation is and can be a big problem for older adults, because we know that individuals who are socially isolated are at an increased risk for developing cardiovascular disease. So this can actually impact your heart functioning. They are an increased risk for infectious illnesses, things like the common cold and the flu. They are also at an increased risk, independently of age, of cognitive decline and of mortality. They're more likely to die because they're socially isolated. Next slide, please. All right. So that's social isolation. That's the quantifiable or objective measure of our social support systems. But loneliness in itself is really a more psychological or feelings-based or subjective basis of our interpretation of our social support system. Okay, so this relates to, are we satisfied or dissatisfied with the frequency or the closeness of our social contacts or relationships? And this is really, again, very subjective. And what's interesting to note is that someone can be not socially isolated. They can have a lot of contacts. They can have a lot of friends. They can have a frequency of they meet for bridge every single week, and they can still feel lonely, okay? So these are not mutually exclusive phenomena. Someone can not be socially isolated and still feel lonely at the same time. And there is unfortunately an interesting study that linked the mortality risk of loneliness is comparable to smoking 15 cigarettes per day. And so loneliness in itself is a killer, okay? And it's really, really bad for our brain functioning. It's bad for our subjective, our well-being, our psychological functioning, and it's also bad for our cognition. Next slide, please. So is this even, relevant in our community? Absolutely, okay? The statistics show that 1 in 2 over the age of 60 in our community are at risk for social isolation. And in individuals who are community dwelling, meaning that they're still living in their homes, 1 in 3 older adults report experiencing loneliness in the last year. So this is 33% of our population. That's a huge proportion of individuals that are reporting that they're dissatisfied with their experiences socially, and that social dissatisfaction is leading to that subjective experience of loneliness. Okay, and in community dwelling individuals, it's 1 in 3. But we also know that older adults are more likely to have chronic medical conditions that are more likely to cause them to need higher levels of care. So things like nursing homes or assisted living facilities or skilled nursing facilities. And individuals who are living in these type of communities are 2 times more likely to report loneliness than someone that's in the community and that's dwelling independently in their own home. So it's really important that we recognize that, yes, this is important for individuals who are living in our community, both in their homes, but also in these institutions or higher level of care. Next slide, please. So what are some of the risk factors for social isolation and loneliness? And I can really break it down into 5 different types of risk factors. And it's kind of like that these are cumulative. So if you have more of these risk factors, that individual is more likely to report loneliness or that subjective feeling of not being validated or heard or understood. The first is the social constraints or risk factors. So things like living alone, the loss of your significant other or partner, family separation, or even being a caregiver or a care partner, all of these are risk factors from a social standpoint for developing social isolation and loneliness. There's also psychological factors, and it unfortunately makes sense with depression and anxiety, because when we're feeling depressed or feeling anxious, we're more likely to withdraw from our social support systems. And when we withdraw from those social support systems, that can lead to social isolation and chronic loneliness. And social isolation. This is really the decreased mobility, poor health, serious chronic illnesses, or loss of independence. There can also be economic factors which increase loneliness. So someone that might be living only on, an income of limited means, or that they live on a very strict income with a minimal budget, might not be able to engage in activities which cost money that are socially active or engaging. And so we need to really figure out how to be sure to engage those individuals, even if they have limited financial means. And then there's logistical. And I think this is really important right now with COVID, with everything that we're talking about. So there's the logistics of we are staying at home right now to prevent the spread of this epidemic, of this virus. And that's a risk factor. That's a logistical risk factor for isolating or for chronic loneliness in our older adult populations. But other logistics, things like if a person loses their driver's license, or they don't have access to public or transportation, or transportation that is actually reliable, this could lead or be an increased risk factor for loneliness and social isolation. Next slide, please. So the research does suggest there is a strong link between loneliness and future cognitive decline independent of age, okay? And there's two mechanisms about why these connections might actually be there, things that are hypothesized to actually be causing why loneliness causes cognitive decline in older adults. The first relates to something called the HPA axis. It's a very fancy term. Basically, it's the hypothalamus pituitary adrenal gland network, which is involved in our body's stress response, okay? And when our body is experiencing stress or fear or danger, the HPA axis goes into full-blown drive, okay? And it starts releasing the cortisol or stress hormone. And it's really intriguing that research has shown that in individuals who report chronic loneliness, their HPA axis is pumping cortisol into their bloodstream, even though there's no actual danger or fear or something in the environment. And so they're actually having long-term cortisol levels because of loneliness, and higher cortisol levels in themselves can damage cells in the brain and in the central nervous system. And this specifically damages the dendrites, the areas around the gray matter, which are in charge of receiving information from other neurons. It also can cause neuronal death, so it actually can kill the neurons. Long-term cortisol levels can. And this has been found most often in the frontal and the hippocampal regions. And the hippocampus is so important for our memory system. And the hippocampus is actually what's involved earliest in Alzheimer's disease. So we see that independent of other factors, cortisol can cause neuronal death and changes neuroanatomically because of chronic loneliness. So you're actually having neuroanatomical changes because of this subjective or psychological feeling of loneliness. Next slide, please. So it's hypothesized that the HPA axis is involved, but also our body's inflammation process is also involved when we're experiencing chronic loneliness. So lonely individuals are highly reactive to stress. And over time, this activates something called the glucosteroids, okay? And this can lead to inflammation, which can dysregulate the neurons in our brain. And so this is really two components. It's the HPA axis is on overdrive and pumping cortisol into our bloodstream, which impacts our cells in our brain. And the inflammation process is not being efficient when we're experiencing chronic loneliness. So these are the two main hypotheses for why loneliness actually causes changes to the nervous system. Next slide, please. So Evans et al. Did a great meta-analysis where they really wanted to assess longitudinally the association between social isolation and cognitive functioning in later life. The benefits of a meta-analysis are that you go into the literature and you're doing a literature review of all studies that meet a specific criteria. And by doing that, you are able to then aggregate or be able to make a bigger statement about multiple studies and making those statements and those conclusions have bigger bang for your buck, so to speak, and be more powerful in understanding their effect size, as opposed to one study or two study with a small sample size, because you're really pooling all the participants in all those studies that are being done in a meta-analysis. So Evans et al. Did a study where they found 51 articles. And when they pooled all those participants together, they had over 100,000 participants that were measured in some way, social isolation and cognitive functioning. And what they found is that lower levels of social isolation, so being higher engagement with your social activity or having stronger or bigger social networks, was associated with better late life cognitive functioning. And these, again, were longitudinal studies. So we had baseline assessments of their social isolation, and we had baseline assessments of their cognition, and we followed them over time. And we found that individuals who had higher social engagement or less social isolation had better cognitive functioning across time. Next slide, please. The Wilson et al. Study is one of the first ones that really demonstrated that how social isolation, loneliness, and the development or risk of development of Alzheimer's is so crucial. And they actually looked at the Rush Memory and Aging project. And Wilson et al., the second author, actually is one of my former mentors from Chicago. So I knew Dr. Kruger, who published this study in 2007. And basically what they did, this is a longitudinal study, so they looked at loneliness and cognitive functioning at baseline, and then they followed them 4 years later and repeated the assessments. The average age for this sample size was 80 years old, and they followed 823 individuals in this project at pre and post. And during that 4 years, 76 of these participants developed Alzheimer's or met the clinical diagnosis of Alzheimer's. This Rush Memory and Aging project also does a lot of autopsies for their participants, and so the participants actually donate their brain to science afterwards. So a lot of times in other papers, they can actually have autopsy confirmed Alzheimer's. But for this study, it was just clinical diagnosis of Alzheimer's. They were still living. And what they found was that the risk of developing Alzheimer's more than doubled in individuals who were lonely at baseline compared to individuals who were not lonely at baseline. And what's unique about this is that this relationship still held even after controlling for social isolation at baseline. So this is more information or more support in the literature to say that it's not just that their social networks, the size of them, or that social isolation that was causing the cognitive decline. It is actually that subjective experience of loneliness, which is causing future decline in your cognition and putting you at a greater risk for developing something like Alzheimer's. And they found also that loneliness was associated with lower levels of cognitive abilities at baseline and a more rapid cognitive decline at follow-up. So again, we're seeing this psychological or subjective construct really being predictive at the rate of decline in cognition, but also who develops cognitive decline and who doesn't. Next slide, please. All right, we got 2 more studies to go through. So Shanker et al. Was another longitudinal study where they had over 6,000 participants with the mean age of being a little bit younger at age 65. And they were trying to evaluate the relationship between social isolation, loneliness, and cognitive functioning over a 4-year period. And basically, this is very similar to the last study for Wilson et al. They found very similar studies, okay? So baseline isolation was associated with a decline in cognitive functioning, independent of those baseline scores. Loneliness in itself was associated with a decline in immediate and delayed recall. So if we think back to that piggy bank, loneliness at baseline was associated with a decline in being able to encode or deposit information into the piggy bank and being able to retrieve or withdraw information from that piggy bank. And there's a really interesting interaction that happened too between education, loneliness, and delayed recall, in that individuals who had lower levels of education for some reason and who were reporting isolation and loneliness were more likely to have a lower or worse delayed recall than individuals with a higher level of education. And this gets into maybe potentially the impact of cognitive reserve, which I'm not going to talk about today. But that was interesting that individuals with lower levels of education and loneliness had different outcomes as opposed to individuals with higher levels of education. All right, next slide, please. Okay, and this is the last study that I'm going to talk about. So this again was another longitudinal study. They followed individuals over 3 years, and basically they did a hazard analysis where they were determining, and they were breaking people up into groups and determining who's more likely to develop dementia and who is less likely to develop dementia at follow-up. And they found that older individuals who were reporting greater loneliness were more likely to develop cognitive decline or dementia at follow-up. Interesting enough, again, social isolation was not related to risk of cognitive decline, but loneliness was. Next slide, please. Next slide, please. All right, so now we know the detrimental impact that loneliness and social isolation could have on cognition. So what do we do to try to reduce loneliness in our community, okay? And it's really important to know that this needs to be an individual tailored plan, because somebody could be lonely or experiencing loneliness for a lot of different reasons. And so there's not one size fits all. We really have to break down what is getting in the way and why is a person experiencing loneliness. Is it that they have some limited social skills, okay? They're not really able, they might have some social anxiety. They're not really able to pick up on the verbal and nonverbal cues, and that means that they're isolating and then they're feeling lonely because they're not engaging social support. So how we combat this is that we do interventions to improve social skills. We do social skills training. We can do this with a therapist. We can do this with a counselor. Maybe the person is feeling isolated because they have a low level of actual social support. So how we combat this is we need to increase their social support. So maybe we do things like having friendly visitors, or we do virtual connections with groups, or we bring in-home support for the individual, or we use something called the AARP Connect to Effect, where all these other organizations can actually bring people into the home so that people can have those interactions and feel less lonely and have that increased social support. Maybe they also do have these limitations to the social interactions. And so this again is trying to increase access through both community, federal, and local supports, as well as harnessing your neighbors, harnessing other members of the community to increase those social interactions. And maybe somebody is feeling lonely because they're having unhelpful thoughts about how they're being perceived in social interaction. So this could be someone with significant social anxiety where they're thinking that the other person is judging them, or they're having unhelpful thoughts that, everyone is going to make fun of them, or there's no point in this. And the way that we combat these unhelpful cognitions is we use cognitive behavioral therapy to tackle, are these cognitions that we're having, these thoughts, are they helpful or not? Are they balanced or not? Are we jumping to conclusions? Are we making errors in our thinking? And being able to kind of learn more balanced thoughts through cognitive behavioral therapy. But the underlying message here is that we need to tailor the interventions for the individual's needs. Next slide, please. So some of the strategies that I found for reducing loneliness, especially in the area of COVID, is that we have to be a little creative. So we're not physically able to be as having interactions with other people because we're needing to physically distance or socially distance. But that doesn't mean that we can't engage with our social support networks or try to decrease social isolation and loneliness. So it could be finding one person in whom that you can trust, you can confide in and talk to on the phone. It could be that you're going through old letters or address books or contacting alumni or other organizations that you've been through for contacts and kind of re-engaging with those long-lost friends. It could be something as simple as writing a letter or writing an email and starting a pen pal chain. We could use the virtual platforms as well, so things like Skype or Zoom, but we can also do things like volunteering or even accepting help from other people. So if there's community organizations that are available for increasing social support, saying yes and having them come into your home and help. It's also can be helpful to kind of think about what your leisures or your hobbies are, because it's easier when you're doing something to be able to have that small talk and have that chit chat and be able to feel validated and heard. So sometimes having an activity to do or a hobby to do at the same time can kind of help break the ice, so to speak. And you really want to try to connect with others in places that you already go, okay? And if you feel like, well, I don't know what to say, or I don't know what to do, trying just to remember that people will remember more about how you made them feel than if you said something the right or wrong way. So if you're trying and you're sincere and you're genuine, most people are more likely to gravitate towards that and engage with that type of person, as opposed to scrutinizing or worrying about if a person said something correctly or incorrectly. Next slide, please. And then I found some national as well as local agencies and resources for reducing loneliness. So the Area Agencies of Aging has over 620 organizations across the United States, which provides information and assistance with things like nutrition and meal programs, caregiver support, and more, which can be helpful at reducing loneliness and isolation. The Elder Care Locator is another great tool. This is a free national service that helps you find local resources for seniors, such as for transportation, if that's what's getting in the way, for caregiver support or financial support if you have the limited means and that's what's resulting in social isolation or loneliness. The National Council on Aging and the AARP are also great resources. But at the local level, the Aging and Disabilities Resource Center of Brown County is pretty top-notch. And they have a lot of events. If you just go to their website on their calendar, they have social events, they have the Memory Cafe, they bring in speakers, they have activities, you can play games, you can do arts and crafts. All of these are socially engaging. Now with COVID, a lot of them have become virtual, so you just want to make sure that they're still meeting, or if they're not meeting, how they're meeting on the platform for the virtual versus in-person. But looking at our local community through our parks and recs, or looking through the Aging and Disabilities Resource Center, or through our Brown County Library system, all of these would have more local supports for being able to tackle loneliness and isolation. Next slide, please. So in conclusion, normal aging, there's natural normal changes to our thinking skills as we age, most importantly in our processing speed, attention, and memory. Dementia in itself is not a part of our normal cognitive aging, and there are changes to the white matter and the gray matter structures in normal cognitive aging. Loneliness and social isolation are different psychological constructs, and loneliness in itself is an increased risk factor for developing cognitive decline in the future. Higher social engagements and larger social networks are associated with better cognition later in life. And when we're thinking about interventions at the social isolation or loneliness level, we want to make sure that they're person-centered and tailored to the individual. Next slide. Thank you so much for your attention.
All right, thank you so much, Sarah. That was wonderful, and I hope you all learned something. I know I learned a ton. So we have some time for questions, and I see that we have had a couple of questions come in. So one of the first one is about select and divided attention. It says, has a study ever been done on diagnosed ADHD? And it says leading to Alzheimer's, but I'm guessing we're talking about, would that potentially increase the risk for Alzheimer's disease?
So not that I'm aware of. So ADHD is more of a neurodevelopmental condition. So that just means that it's diagnosed in childhood or adolescence. That's when the symptoms have to emerge. I'm not aware of any literature that would suggest that having ADHD as in itself is a risk factor for developing Alzheimer's. But it's definitely that executive functioning, the divided attention, selective inattention, those networks which are being impacted in something like ADHD, which is why things like medication or behavioral management strategies for trying to increase impulse control or emotion regulation or being able to decrease our inhibition or ability to kind of focus on other things in the environment are the gold standard treatment for ADHD.
Thank you. There is another question here that says, if lack of physical activity due to chronic disease, such as rheumatoid arthritis, fibromyalgia, makes someone more likely to get Alzheimer's disease along with loneliness, which increases inflammation. Is this a double-edged sword?
It most definitely is a double-edged sword. And at the same time, we know that physical activity, social engagement, and cognitive stimulation, even in individuals with mild cognitive impairment, can slow the progression down and can prevent the rapid conversion from mild cognitive impairment to dementia. So even if somebody does have mild cognitive impairment or physical limitations or cognitive limitations, we still need you to be engaged and active physically, cognitively, and socially. It could be that we just have to modify these a little bit. So American Medical Association recommends 150 minutes of moderate intensity exercise a week. And think of it like movement as medicine. But as we age, we also need to make sure that we're taking into account strength training and balance training just as much as cardio training. And there's a lot of research to suggest that individuals who have Alzheimer's, even the dementia or the mild cognitive impairment of Alzheimer's, they can benefit greatly from physical activity.
Thank you. We have another really good question here, which is that you mentioned that increased cortisol levels can kill neurons. If a person experienced childhood trauma, could they be at a bigger risk for developing an irreversible dementia?
Oh, that's a great question. So I don't know any studies of that, but anecdotally, I would say that yes, we know that individuals who have experienced trauma or something like meeting criteria for PTSD, that this HPA axis and the connections between where emotions are housed, the limbic system, these connections actually do change. However, we know that neuroplasticity can happen, okay? So this means that there's other areas of the brain which can be, taken aboard to help with any of these cognitive changes or any of these structural changes to the neurons. So just having childhood trauma in itself or experiencing, any kind of traumatic event, I don't know if that is an increased risk factor for developing dementia. But there definitely are neuroimaging studies to show that the connections in the brain have changed for these individuals. However, I do know of a study, I did my fellowship at the Minneapolis VA, and I do know some of the research that they were doing for individuals with PTSD, that even though they had changes to the connections of their brain, doing psychotherapy that's evidence-based can actually impact neuroplasticity and change the networks of the brain so that they function better. So it's not just, I've had trauma, I've had something awful, and there's nothing I can do about it. There's neuroplasticity that can happen at any stage, and psychotherapy can be a great way to actually change the connections in the brain, change those pathways.
Wonderful. And I think that's what's so exciting about a lot of the information in this presentation is just that sometimes in this field of cognition and dementia, it can feel really like we don't have a lot of control. And so it is exciting to hear about that type of research that is being done that reminds us that we do have some control over our cognitive function. Obviously not as much as we'd hope to, but we do have some control. So
neurogenesis, or the creation of new neurons. It used to be that we only thought that happened in early childhood and adolescence, but neurogenesis and new connections, what's called synaptogenesis, can occur at any age. So it's not true that old dogs can't learn new tricks. You can learn at any age.
Yes, that's an excellent reminder. So for those of you who have joined us either by the phone or on the computer, I am going to change the controls here that allow you to either mute or unmute yourself. So if you wanted to take yourself off of mute and ask a question, you will be able to do that. So I am just going to click that button here, and you now should have the power to mute or unmute yourself. So if you have any questions, feel free to unmute. Okay, so I'm also going to, okay, I thought we had
hold on. You know, hi, no, it's Sherry. I have another question. Okay, so you mentioned that the loneliness is really the perceived loneliness. So is there like, would we focus more on helping people understand their perception, like behavioral therapy? Like, is that something where we would really want to focus on changing that perception? Because people, like you said, can be completely surrounded by their loved ones and busy and still feel lonely. So sometimes just throwing more stuff at them to do or more people around them isn't going to fix it.
Correct. Yes. And that's exactly what cognitive behavioral therapy is all about. It's really changing if we get stuck in what are called unhelpful thinking styles. So sometimes we jump to conclusions, or we think all black and white, or we try to do mind reading where we're thinking or anticipating what the person is doing, and that's going to influence our thoughts or feelings or behaviors in that social interaction. So it's really catching those thoughts, checking those thoughts. Are they balanced? Am I missing something? Is it judgmental? And then being able to change those thoughts. And these are habits that have been formed, these kind of automatic thoughts or thinking styles that have been formed as we grow up, based on our experiences, based on our culture, based on everything. But we can still kind of take a step back and say, am I misperceiving something? Am I misinterpreting something in this social interaction? And that's what's leading me to have this unpleasant emotion of not feeling validated, not feeling understood, because that's what social relationships are all about. And that's why we engage in social interactions, is to feel validated, to feel understood, to feel like that we can provide that support to a person, but it's also reciprocal. They can provide support to us. And we're social creatures, so we really get a lot of meaningfulness and connection from our interactions with other people.
Refer people to counselors.
Yeah. And it could be also just social skills training. 80% of our interactions are nonverbal cues. Okay, so it could be anything from our eye contact or our body language, our posture. It could be, other things that we're sending out to the other person that they might misperceive as being, I don't want to engage with that person. So it could be something as, we need to teach you some social skills training, and that's going to make you a little bit more confident in social interactions, which then would likely decrease the loneliness that you feel because you leave that interaction with a more positive response as opposed to a negative one.
Wonderful. Okay, so thank you so much, Baumgartner. I learned a lot, and I am sure that everyone else did as well. We've had some great questions. If you guys have any other questions, feel free to chat them in here. I'm just going to give a couple of reminders. One is that we will send out an email next week, which will have the recording, a link to the recording for you to view, as well as an opportunity for you to provide us with some feedback, such as how you learned about it and topics you'd want to hear in the future, things like that. So we really, really appreciate your time. And again, this is an opportunity that is brought by the Brown County Dementia Friendly Community Coalition. If you're ever looking for a way to get involved in your community, I am certain that if you're in our area, we would love to have you if this is an area of interest for you. Many communities have a coalition like this statewide, so if you're interested in this, I am sure that we'd be able to connect you with someone in your area. So thank you, everyone. Have a wonderful weekend. And thank you, Dr. Baumgartner, for your time.
Thank you. Everyone take care.
You too.